Now coming to infection in burns. So the causes, there is the increased chance of infection in burns we have already discussed. There is a burn wound. The patient will be immunocompromised. The gut, there will be increased chance of translocation of bacteria. The lung, there can be chemical pneumonitis and inflammatory changes. There is multiple portal of entries for pathogens in form of vials, tubes, cannulas, etc., catheters. So we have to prevent infection and we have to identify the infection. So the prevention of infection, make sure we have take sterile precautions and there should be bacteriological surveillance. That means we should take culture and sensitivity periodically and we should take the, when we take remove the central line, look for the culture and sensitivity, take urine culture and sensitivity, do blood culture and sensitivity every 5 to 10 days like that. So we have, or when there is a fever, we have to go for a bacteriological surveillance to prevent the infection in case of burns. How will we identify infection? There will be increased blood count. There is, can be thrombocytosis, and there will be features of increased catabolism, weight loss, increased sweating. Like that, there will be features of increased catabolism. So that is how we prevent and identify. The treatment will be based on the bacterial surveillance and the appropriate antibiotics will be selected based on the culture and sensitivity. Now, other aspect of burns care. One is the nursing support. If there is no adequate nursing support, burns management is impossible because there is daily dressings, washing the patient, care of the catheters, care of the tubes. All this can only be done properly by a proper nursing support. Next is physiotherapy because there is increased chance, there is a more of a deep burns, there will be more contracture. So if the patient is standing like, if the patient is keeping their hands like this in case of a hand burns, there will be increased chance of contracture. So we have to go for a proper physiotherapy, especially in case of arm burns. In case of an axillary burn, there is increased chance of contracture. To minimize the contracture, physiotherapy should be done and the contractures has to be minimized. And finally, psychological support. After we have done all this, what happens is the burns patient will have depression, and many a times the burn patients will attempt suicide, and sometimes the burns may be suicidal burns. So in those cases, those patients, burns patient should require a psychological support. Now, what about the surgery in burns? We have already said that the depth of the burns can change. So we should reassess the burns after 48 hours and see whether the depth of the burns has changed. Though it is still a superficial burns, it is a deep partial thickness burn or has it become a full thickness burn. So we have to reassess the burns after 45 years. And all full thickness burns require surgery. If it is not a small burns, less than 4 centimeters square or so, first all the full thickness burns will require surgery. And deep partial thickness burns will also require surgery. If it is generally, it will not heal with less than 3 weeks, within 3 weeks. So deep partial thickness burns will also require tangential shaving and skin grafting. So this is the method of tangential shaving with the help of a graft blade. Now, there are two aspects in case of surgery. One is anesthesia and by the surgery itself. There is a high amount of blood loss in case of surgery in burns. So the patient should have a central line, an arterial pressure monitor, a wide bore cannula, and the blood transfusion should be ready. So we have to monitor the fluid and blood circulatory status in the patient. Now coming to the surgery part. We should give subcutaneous adrenaline to minimize the bleeding while we do a tangential excision. Tourniquet shade should be placed around the limbs again to minimize the bleeding. Then excision of the dead tissue should be done until we see a bleeding points. In full thickness burns, the depth should be up to the subcutaneous tissue or the facial plane. In partial thickness burns, deep partial thickness burns, the tangential excision should be done like that until we see pinpoint bleeding from the dermis and a viable dermis. And after we have excised, we have to give some sort of a wound cover. If it is a small area burns, we can give a permanent wound cover, or if it is a large area, we have to go for a temporary wound cover. So timing, it is earlier the better. Even though it will take 48 hours to evolve, if it can be done earlier, it is better. But many a times the hemodynamic status or the setting in the hospital, if it is a rural setting or a rural tertiary care setting with no burns unit, many a times this surgical excision will not be able to do surgical excision on an early basis. It will be generally delayed only for those surviving patients. The excision, which are the methods by which we can do excision? One is the tangential excision we use with the graft blade in case of a deep partial thickness burns. Excision need not always be with the blade itself. We can use a sharp jet of water like a Versa jet and use its suction force and the suction force of that Versa jet water and use for debridement. And then is the enzymatic debridement. You can put an ointment, an enzymatic ointment, and use for debridement. So these are the different methods by excision, by using a Versajet or using an enzymatic debridement. We can excise the devitalized tissue in burns. The tangential excision is the most common method used. Now, once we excise the skin, we have to give some sort of a cover. One is the most commonly used is skin grafting, especially when it is a smaller area of burns, we can graft from another site. So generally the burn area would be large. So if we take a sheet of skin from another site and put it like that, we are making another raw area. So we have to mesh the graft like this. Using the measure, we have to mesh the graft like this so that a small piece of skin can be used for a larger area of skin, larger area of the burn wound. So the grafting meshing can be done in a 1:3 or a 1:4 or 1:5. There are different ratio. That is, one part of the skin can be used for a 5 part of burns. That is 1:5. The meshing can be done in different methods like that. So the more the meshing, the more the chance for some amount of scarring. Lesser the meshing, better the scarring. So in full thickness burns, lesser meshing is not done, especially in face, because there will be more scarring in case of a meshed skin. Then we can use for a temporary cover, we can use a cadaver skin. If it is a large area of burns, we cannot do an autograft. So we can do a xenograft or we can do a cadaveric skin graft. For cadaveric skin graft to be done, we have to have a skin banking, where we can take the cadaveric skin from the thigh and bank it like this in a refrigerated setup and use it later. And also we can use amniotic membranes as a temporary cover. Another method is skin substitutes like that. Skin substitutes can be like alloderm. It can be either an epidermal substitute or it can also have a dermal component. In epidermal substitute, there will be only a few layers of the epithelial tissue. It can be cultured. The layers of the epithelial tissue from the patient can be cultured into a few sheets and can be used as a skin substitute. Or in dermal component there will be commercially available skin substitutes like allodum. What they do is that what these skin substitutes actually do is they act as a scaffold through which the tissues can grow inside. So the tissues can grow inside and this will be absorbable and the new skin can be formed over these scaffolds. So it can be, as skin substitutes can act like that. Now, post-operative care, again, there is increased amount of blood loss. There should be adequate hemodynamic status should be maintained post-operatively. Patient will be in pain, so ventilation and analgesia and anesthesia care should be given in the post-operative period also. So everything is excised, proper cover is obtained. So is it a happily ever after? No. The burns patients, the treatment, apart from the burn care, there will be post-operative problems. The long-term problems like contractures will be there in the burns. What are the long-term problems? Delayed reconstruction and scar management. So one is contractures. Contractures can be managed by Z-plasty, full thickness skin grafts, and vascularized flaps. Then exposure keratitis. The same thing contracture can happen on the eyelid also and result in exposure keratitis. There is corneal involvement here. So in those cases, the lid has to be the earlier grafting of the skin over the lid should be done. Then burn alopecia is a common thing. You can see a burn alopecia. In those cases, tissue expansion can be done, and those tissue can be used for the grafting of the in the area of the burn alopecia. So regarding the burn alopecia, and then is the hypertrophic scar. In hypertrophic scar in the burns, pressure garments and intralesional steroids like triamcinolone is the treatment. Just a word about the difference between a hypertrophic scar and a keloid scar. Keloid scar will go beyond the margins of the lesion, whereas hypertrophic scar will be inside the margins of the lesion. We have discussed about the proper management of burns, and we have discussed about the post-operative care or a long-term care. But what about the pre-hospital care? What happens pre-hospitally? How will we prevent the burns? How will we prevent further burns? So pre-hospital care, the mnemonic can be check. One is we have to check the burn. So suppose we have a burns, we have to stop, lie down, drop and roll to prevent the increased burn disease. Stop, drop and roll. Suppose we have our shirt got on fire, don't run with that into the nearby pond. You stop there, drop into the ground and roll. Now next is cool the extremity to decrease the amount of decrease the zone of coagulation. You have to cool with the running water. Make sure that the water is not too cold so that the patient will go in for hypothermia. Then elevate the limb to decrease the edema, and finally you have to give the oxygen for patient to prevent the hypoxia. So these are the pre-hospital care in case of burns. Now all this is that we are equipped and ready to manage a patient who is coming to the casualty. But suppose our neighbor come with the burns in the skin, will get, how will we manage? So what is the management of outpatient burns? Local burn care. Should we burst the blister or not? Yes, we generally blister bursting is not required. It should not be. It will get healed by its own. Suppose it is a ruptured blister already, don't keep the excess skin there because there is a high chance of infection. Then clean the wound. Blisters can be left alone. Now topical agents like silver sulfadiazine can be used anywhere in the body. But in case of a pregnant patients or a nursing mothers or in case of an infants, there can be systemic absorption of silver sulfadiazine. And in case of a if we apply the silver sulfadiazine, there can be a bluish discoloration can happen. So in those cases, silver sulfadiazine need not be used, soframycin can be used. So anywhere in the body, silver sulfadiazine, but in case of face, soframycin. Now, dressing of a minor burn wound. So, what are the, we have already told about the dressings of the burn wound. So, what are the layers of the dressing? The first layer should be a non-adhesive Vaseline gauze, Sofratule. The second layer should be our gauze, and which absorbs all the fluid from the excess fluid from the burn. And the third layer should be the bandage. These are the dressing for the burns. And healing of the burns, we have to look for, when we review the patient, we have to look for whether there is an infection in the patient. Because if there is an infection, there will be increased, the depth will get increased. So give antibiotics to the patient if necessary. And if there is itching, you can add a gabapentin. Analgesics SOS. Now we have discussed all the other aspects of burns. What is remaining is the non-thermal burn injury, which we will discuss in part 4.